So can you talk about what available treatments we have for HFpEF?
Absolutely. So the landscape of treatment for HFpEF has evolved greatly over the last couple of years. I think central remains addressing and managing comorbidities. And so, really making sure we're treating their hypertension, their coronary disease, we've optimized their diabetes treatment, we're thinking about obesity. And then, that aside, we're really looking at evolving treatment with what I call GDMT or guideline directed medical therapy. What are the components of currently? I would say there have been two pivotal trials that have really put SGLT2 inhibitors as first line for anybody with HFpEF. Those two trials were Emperor Preserve and Deliver, and they looked at treatment with either empagliflozin or dapagliflozin. Currently, in the American Heart Association, American College of Cardiology guidelines, SGLT2 inhibitors have a class 2A indication. But recently, actually, the European Society of Cardiology moved these medications to a class 1 indication for patients with HFpEF. And I suspect the US guidelines will follow it. So I would really say SGLT2 inhibitors should be broadly considered. The other medication classes, there are two. The first is angiotensin receptor neprilysin inhibitors, or ARNI. The trial that looked at the use of these agents is called Paragon HF. The overall trial was neutral, but subgroup analyses showed some potential benefit in people with what they called below normal EF, and interestingly, also benefit among women compared with men. So currently, ARNI use deserves a class 2B indication in the US guidelines. And I would say that we're using them mostly in people who have persistent symptoms on an SGLT2 inhibitor, also have evidence of hypertension, and in particular in people with below normal EF or in this awkward category of heart failure with mid range EF. And then the last class of medications are mineralocorticoid receptor antagonists. Spironolactone specifically was studied in a trial called TopCat. The trial, again, was neutral, but had really interesting geographic variation in treatment effects. And so currently also is listed as a class 2B indication. And then lastly, we know that certainly loop diuretics for treatment of congestion is sort of the one class medication in the US guidelines right now. So in terms of a general approach, I would say I typically consider SGLT2 inhibitors broadly in everyone. When there's congestion present, I actually really like potentially considering upfront mineralocorticoid receptor antagonists because they can treat some of the congestion and may minimize your use of a loop diuretic. But if people still have congestion, then of course we're using loop diuretics. And then in the setting of persistent symptoms with blood pressure room, I would consider RA. So those are sort of the medical therapies that we have to date. There's a lot of excitement around an evolving role of GLP-1 receptor agonists. There were some promising data recently published and presented with a trial called that showed that GLP-1 receptor agonists in patients with HFpEF resulted in a sustained weight loss, but also really remarkable improvements in quality of life and also 6-minute walk distance. We don't have trials powered on outcomes just yet, but I think this will be a quickly evolving landscape.
Well, we
Yeah,
covered a
go
lot
for
of
it.
material. So just to recap, it sounds like first, we're going to make sure that we're appropriately treating all of the risk factors that are contributing to their HFpEF. And then our mainstay of treatment is our SGLT2 inhibitor. After that, plus or minus MRAs, ACEs, and ARBs, and then diuretics for symptom relief. And in the hospital, we hear all the time not to use beta blockers in patients. Can you walk us through that logic?
That's a great question. So, why are we concerned about beta blocker use in patients with HFpEF? I would say if the patient has another indication for beta blocker use, they have coronary disease and just had a myocardial infarction, they have atrial fibrillation with difficult to control heart rate, then of course we should be using beta blockers. But on the flip side, we know that chronotropic incompetence is a huge problem and actually can lead to really decrement in functional status among patients with HFpEF. And so often when there's not another obvious indication for a beta blocker, I will actually try to down titrate beta blockers or even stop them altogether in patients with HFpEF to see if that helps with respect to exercise intolerance.
How do you decide what volume maintenance this human with this stiff ventricle needs?
That is a really great question. And I think a lot of sort of picking a diuretic dose is unfortunately still trial and error. I think, of course, people with concomitant chronic kidney disease might have higher diuretic requirements. In general, if someone is diuretic naive, I start small and we just have to see how it goes, right? So LASIK 20, 40. In somebody where they're becoming more diuretic resistant, or you're worried about some component of tricuspid regurgitation or right sided heart failure, that's a big component of their presentation where they might have trouble absorbing medications. We often sort of anecdotally say torsemide has greater oral bioavailability, and so they might do better with torsemide. So in the setting of severe TR or right-sided symptoms, often we reach for torsemide. Otherwise, if someone is loop diuretic naive, I would say start with furosemide or Lasix, low doses. But I think unfortunately a big part of it is still trial and error and monitoring the